Welcome to the webinar. I'm David Hayes, Chief Medical Officer of BIOTRONIK Inc., and I'm delighted to have this opportunity to be with you. Thanks for taking the time. For today's discussion entitled Master the Pace, Advancing Knowledge of Conduction System Pacing Using Stylet-Driven Leads, I'm happy to say we have attendees registered from over 75 countries around the world. I'm delighted to be joined by two speakers with a depth of experience in conduction system pacing, Dr. Larry Chinitz and Professor Zach Whinnett. I will introduce each of them in more detail before they speak. Each speaker will make a 15-minute presentation, and we will have time for Q&A after both talks, and then an open discussion at the end. Also, at the very end of the session, there will be two questions that come up automatically, and we would request that you take a few seconds to respond to both. We encourage comments and questions. Please type your questions into the chat, and we will try to cover as many as possible. You will not see all of the questions being asked, but we will have access to all of them. First, I'm delighted to introduce Dr. Larry Chinitz. Dr. Chinitz serves as the Clinical Director of Cardiology, Director of Cardiac Electrophysiology, and the New York University Heart Rhythm Center, and co-director of the NYU Langone Heart and NYU Langone Health. He graduated from New York University in New York and completed his residency and fellowship at NYU. Dr. Chinitz is an internationally renowned expert in the management of heart rhythm disorders. He established NYU Langone's clinical cardiac electrophysiology program and the Heart Rhythm Center to provide state-of-the-art cardiac rhythm management of atrial and ventricular arrhythmias. His current research focuses on the development of novel technology for use in catheter ablative therapies, the investigation of neurostimulation and pharmacotherapy to help regulate irregular heartbeats, and other innovative treatments for patients at risk for sudden cardiac death. He has long been at the forefront of emerging therapies in cardiac rhythm management and has made very recent contributions in conduction system pacing as the primary investigator for the BioConduct study. And today, Dr. Chinitz will talk about lessons learned from BioConduct. Dr. Chinitz, thank you.
Good morning, David. Good morning, everyone. It's my privilege to present to you today on our experience with conduction system pacing, specifically the BioConduct trial, and some other things that we've learned through the course of treating patients that have been enrolled. Okay, these are my disclosures. So we had the privilege to present the BioConduct trial at the heart rhythm meetings last year. The Conduct trial was left bundle branch area pacing using a stylet-driven retractable helix lead, early results from a prospective multi-center IDE trial. Left bundle branch area pacing is known to be a safe and effective alternative to right ventricular pacing, but there has been limited prospective multi-center data on the use of retractable helix stylet-driven leads. This study was a prospective study evaluating the safety and implant performance of a currently available stylet-driven retractable helix pacing lead when used for predefined left bundle branch area pacing. You know, there have been many studies over the years, especially over the last 4 to 5 years, that have shown success with stylet-driven leads for conduction system pacing. And we'll go over this a little bit more as we go along. The study design was, as I said, multi-center, prospective, non-randomized. We're evaluating the performance of the stylet-driven Solia lead when implanted in the left bundle branch area. The primary efficacy endpoint was implant success to pre-specified criteria, which turns out to be really important. And the primary safety endpoint was freedom from lead-related serious complications through the first 3 months, and this was pre-specified to the FDA. So the most important point is, what was the efficacy? What constituted successful placement of the left bundle branch area pacer? And it was predefined such that patients should have had at least two of these four criterias. So criteria 1 was a right bundle branch pattern in V1. Criteria 2 was a peak LV activation time in V6 of less than 90 milliseconds. Criteria 3 was actually visualizing a left bundle potential, and criteria 4 was demonstration of output-dependent transition from non-selective to selective or non-selective to septal pacing. This has occurred a lot of interest recently, especially with the European guidelines that have been sent out about what really constitutes left bundle branch pacing, what's left bundle area pacing, and what is septal pacing. And the distinction is quite important. And as I said, there's much discussion, and this is the publication that was in the European Journal on the ERA clinical consensus statement. So just as a background, you can see that methods of physiologic pacing can include His bundle pacing, left bundle pacing, left fascicular pacing, or left septal. And this diagram can show you the differences. Conduction system pacing encompasses His bundle, left bundle, and fascicular. Left bundle branch area pacing is left bundle or fascicular pacing and septal pacing. And deep septal pacing is not considered left bundle branch area. In the BioConduct trial, we chose left bundle branch area pacing with two of those four criteria that I described to you. But again, I'll go through these quickly. The differentiation between left bundle selective pacing, non-selective pacing, or septal pacing is really quite important. And here's an example of constant pacing during screwing in the soleal lead. As you could see that the morphology of the QRS goes from RV septum to deep septum to LV septum to left bundle branch capture. And I'll put your attention to V6. You can see that right bundle, that left bundle pattern morphing into a very sharp early peaking R wave. You can see V1 going to a very distinct large R prime in V1 as you capture the left bundle. So as you're screwing in the lead, these changes are really quite important to be able to see. And this is a complex slide, but these were the recommendations of the European guidelines into what constitutes left septal, what constitutes left bundle, and what is left bundle area pacing. And those four criteria that I gave you are the most common ones that are used. But in fact, most time in clinical practice, people are pretty happy with a right bundle pattern in V1, a notched V1, or an early R wave in the lead V6. But one should recognize that that does not define left bundle pacing clearly. Again, here's an example of pacing, of septal pacing versus bundle pacing, selective versus non-selective, and you can see various criteria that need to be shown. So the transition from left bundle area to selective or to septal can be seen by movements in V6, by morphology in V1. I'm not going to go through it all presently, but it's not just good enough to place the lead on the septum. One has to have clearly established criteria that make it important that you show conduction system pacing. And the reason for that is most recently been shown that there are in fact differences in mortality, in heart failure hospitalization, if you truly engage the left bundle as opposed to just being septal. It makes a big difference in outcomes. And again, this is shown in multiple studies. This was a study done by Zhu et al. That was just published in the last few months. But the differences in mortality, in malignant ventricular arrhythmias, and QRS duration, in echocardiographic response of ventricular function were clearly different if you truly engaged the conduction system as opposed to just being on the septum. This is most important for patients with ventricular dysfunction who require resynchronization, and probably a little less important in patients who just have bradycardia. This is a study again by Pugal from Geisinger that again showed that there was a difference in outcome and mortality and heart failure hospitalization depending upon the integrity of the conduction system pacing. So the current criteria that we use to engage the left bundle and to show is transition during decremental output pacing. And I showed you how you can see that during pacing, and this was one of our four criteria. A left bundle potential, if you can actually see it at your lead position, is a very nice example of left bundle pacing. The V6 peak to R wave and V6 measurement is a very important one. The difference between the peak in V6 and V1 can be used as well. Capture beats during the implantation of the lead can be helpful. A current of injury and QRS morphology change during continuous pacing, and transition patterns, most commonly from non-selective to selective or non-selective to septal. If you have these criteria, then you can, in fact, with a greater confidence, be clear that you have engaged the left bundle. So just with that introduction, I go back to the BioConduct trial, and we had these 4 criteria. And the 2 that were most commonly used was the presence of the right bundle or the LB activation time. The lead was the Celia S pacing lead and the Selectra 3D catheter. As you know, the Celia is a 5.6 French stylet-driven endocardial lead, and the Selectra sheaths are very helpful for adequate positioning on the septum. The indications in our patient population, 40% of the patients had AV block, 50% of them had sinus node dysfunction, and then others with heart failure indication or planned AV node ablation. So there were a total of 186 patients who underwent implantation. This slide is very helpful because it can show you the criteria that were used. So, I'm sorry, 94% of the patients had a right bundle branch pattern in lead V1. 99% of the patients had a peak LV activation time of less than 90 milliseconds. So these were the 2 most common criteria that were achieved in most of the patients. Only a smaller group of patients, like 22%, you could actually see a left bundle potential. And then about 38%, we were able to demonstrate output-dependent transition. So I would say that in at least 40% of patients, we clearly had evidence of left bundle capture. In the other group of patients, we definitely had left bundle branch area pacing, but not totally clear whether we engaged the left bundle or not. But again, this is most critical in heart failure patients, and that was a relative minority of the patients that were in BioConduct. The lead performed very well in terms of pacing thresholds and amplitudes. They remained constant post-implant up to 3 months, and this data was very consistent with what is seen with lumenless leads that have been used. The primary safety endpoint of the 178 patients, there were no serious lead-related complications. We did have 3 dislodgements of the leads, but no other serious complications. We did have several right atrial complications having nothing to do with the Celia lead in 7 patients, but an overall complication-free rate of 92% was achieved. Here is the 98.2% complication-free endpoint. We increased the power of the safety endpoint by using a subset of another study that engaged left bundle branch area pacing with the Celia lead. So there were 81 patients from the Biomaster Selectra 3D study, which increased the power of our safety endpoint. And with that combined group of 249 patients, there were a total of 5 lead complications, all lead dislodgements occurring out of 249 patients, resulting in a complication-free rate of 98%. And I think this is pretty substantial given our experience with conduction system pacing and a very early experience with stylet-driven leads. So the overall complication rates was quite low and very acceptable for our group. So the present prospective multicenter BioConduct IDE study through the initial 3-month follow-up period demonstrates that a stylet-driven extendable helix lead achieved left bundle branch area pacing with a very high level of success of 95% and a very low complication rate. And I think for the first prospective study with stylet-driven leads, this is a very substantial outcome. It turns out that there have been other non-prospective, limited, non-multi-center trials, and there are several of them that are out there. I don't know if this audience is familiar with as many as there are, but there have been several, and there's some consistency with the data. So in the Marco de Castillo study, which is very recently published, there was no difference in implant success between stylet or luminous leads. Zero difference in the two. And in fact, stylet-driven leads showed shorter implantation times and shorter fluoroscopy times than the standard luminous leads. The stylet-driven lead had a tendency for favorable left bundle branch capture in Brady patients. There was no clinical relevant difference in stimulation patterns or impedances, and complications were very low. So this is the most recent single-center study that showed very substantial positive gain with stylet-driven leads. This was reported in several studies further back in 2023. The Cano study showed that success was slightly higher in the early cohort with luminous leads, but the lead implant and fluoroscopy times remained lower with stylet-driven leads. But when he looked at his last 100 patients after the operators gained success. Now, this is very important with conduction system pacing of all types, but certainly there are new experiences that are required to learn. But when they looked at the last 100 patients, the acute implant success of the two were not significantly different. And the ability to capture in the left bundle branch area now became sort of the same in the two groups with no significant difference. So we learned a lot with stylet-driven leads, and as time goes on, operators become more experienced with it, and they improve outcomes, successive implantation, and most importantly, engaging the left bundle branch area for these findings. So the principal findings of the Cano study, which were the largest one before ours, were that luminous leads were associated with a significantly higher implant success rate initially. Stylet-driven leads usually were implanted in more inferior and less basal positions in the septum. Acute complications were initially higher with stylet-driven leads, especially lead damage and perforation. Significant QRS morphology changes after implant, but before hospital discharge were more frequent with the stylet-driven leads. They did have faster implant time and reduction in fluoroscopy, but most important, as the operators became experienced, and in the most recent 100 patients, all of those differences seemed to go away. So there are things that we need to learn about stylet-driven leads, but they are very positive. In 2023, there was a physiologic study looking at LV synchrony, comparing SDLs versus LLLs. And in fact, the procedural complication rates were similar, but many patterns of desynchrony, ejection fraction, regional motions were quite similar between the two groups without a substantial difference. Again, this has been reported again in 22, further back, shorter procedure times, less fluoroscopy, and eventually equal implants. So I don't really want to go through them all. So in conclusion, we have a prospective study and we have several smaller studies which have confirmed to us that stylet-driven leads can be equally successful to luminous leads in assessing and implanting in the septum and achieving left bundle branch area pacing. But there are some advantages that we have to think about that exist with stylet-driven leads. First of all, there's a larger lead caliber. So it's a little bit easier to rotate the lead, less bunching up of the insulation, maybe allow us to get even deeper into the septum. That is not true for the thinner luminous leads. The support of the stylet increases both torqueability and septal penetration. The stiffness of the stylet avoids twisting of the lead in front of the delivery sheath. Additional support of the stylet may help to keep the lead position and track on the septum. So it is a firmer lead that may hold better over time. What we like most is that clamps or the jumper cables can be connected directly to the stylet, which facilitate continuous pacing while extending the helix. And I do think that continuous pacing, showing transition, doing your best to show that you truly have engaged the left bundle is very important as we mature in the whole field of conduction system pacing. And wider delivery sheaths of these stylet-driven leads tend to be more supportive compared to the thinner delivery sheaths of the luminous leads, with less risk of kinking and possibly being able to hold the position on the septum a little bit better. So in conclusion, I think we've learned a lot. I think we will continue to learn as our experience improves, and we will use these tools to ensure that we engage the conduction system, which appear to lead to better long-term outcomes for our patients. Thank you.
Thanks very much, Dr. Chinitz. Fantastic talk. So a question that I have, and again, you covered this in detail, but I think it's so important. When BioConduct was designed, a great deal of time went into the criteria for success of LBBAP. And you said that by far the two criteria that were used the most were the right bundle branch block and peak left ventricular activation time. At the end of the study, would you still include all of the four criteria as being good evidence of successful capture, or would you limit it to just a few of the criteria we originally had?
So, David, my feeling about that, and I think we're all evolving. You know, these criteria are less than a year out, and our understanding of what we need to accomplish is evolving. But I think we should differentiate amongst the type of patients, right? When we're dealing with somebody who has heart failure, who requires resynchronization, the outcomes of showing engagement of the left bundle directly is important. So in that setting, I would believe that we should use all four of the criteria, especially transition. I think it's sometimes harder to see the left bundle potential, but I would definitely show that with output pacing, that we see transition from non-selective to selective or non-selective to septal pacing to ensure that we've engaged the left bundle. In the bradycardia population with preserved ventricular function, I think it's a lot less important. It doesn't seem to have the same long-term outcome. So just taking the peak R wave in V6 and having that terminal R wave in V1, I think is an easier output endpoint to achieve, and that's how I would take it.
So, Larry, a question from one of the listeners. Do you prefer to expose the screw before insertion in the delivery system?
Yes, well, you know, it's operator specific. I think we've seen it both ways, but I do like to do that because it just engages the septum, holds its position a little bit longer, and allows me to begin pacing from the beginning as I screw it in or advance it into the septum. So I think for me, that's what I do, but in our group, people do it different ways.
Another question that came in is, what are the ways in which you are confirming from the ECG? Which leads? That is, are you looking mainly at V1, at the inferior leads? What are your go-tos?
Yeah, so usually we highlight V1 and V6, right? Because the changes that we like to see is that left bundle pattern in V6 narrows up and the peak of the R wave in V6 starts to get shorter and shorter. One of the slides I went through quickly showed that, where you have continuous pacing and you can see that changed. Similarly, in V1, it goes from a typical right bundle pattern to a QR or QR prime with a tall terminal R wave in V1, no S wave in V1 at all, to clearly show that you've engaged the left side of the septum. So I think if you concentrate on V1 and V6, you get most of the advantage that you need.
And at NYU, is this now routine for all of your Brady devices to do left bundle branch area pacing?
It is. So we've established the criteria that I've just spoken to you about, or we're trying to establish. But anybody who's going to have a high percentage of pacing, we're going to put in a left bundle branch area pacing. And the rigor at which we go after in terms of showing that we truly have engaged the left bundle will be dependent upon the clinical scenario. But if somebody's going to have a high percentage of pacing, they're going to get a septal lead, yes.
And what would you tell people about the learning curve for stylet-driven lead for left bundle branch area pacing? Certain number of cases they can expect, or what would you say?
Well, I think it's like everything that we do. The more you get familiar with the steps involved in the implantation, the easier it becomes. And I think we saw that in the Cano study pretty nicely. There was marked improvement over the course of the study, and then the results started to get better. Stable engagement of the septum, manipulation of the selectress sheath so it doesn't move too much, carefully watching impedance and morphology changes as you screw in the lead are the critical areas, right? Because you need to get to the left septum, but you don't want to go too far so that you don't perforate. And we're learning about tools like impedance changes, looking at the current of injury on the lead, which is a very powerful way to see that you're getting close to the left side of the septum. So little tricks and tools of stability and what to look for as you screw the lead in. But I think the learning curve is really fast. So this is not a very difficult procedure for physicians who are used to implanting.
So one more question, a follow-up question. Are there any changes in criteria in patients who have a pre-existing right bundle branch block?
Well, the V6 to R time, the peak R time in V6 will be different in the presence of right or left bundle branch block. So one has to understand the differences in that area. So I guess you're referring to patients who have a pre-existing right bundle branch who are going to be paced all the time. Right?
Yes.
So that's not really a heart failure population. That's a Brady population. Yeah. So it's just some of the criteria for successful engagement of the left bundle change a little bit, but they're pretty minor.
And have you seen, obviously there's a lot of focus now in CRM about the tricuspid valve. Have you seen any tricuspid valve complications? Do you see it as necessary to have a post-operative echo? Are you trying to keep a certain distance away from the tricuspid valve? Any pointers there?
Well, that's a difficult area now because, you don't have a lot of leeway in terms of where there's a little bit of variability in where you can implant in the septum, but we need to be at the conduction system. So we don't have a lot of choices on how that lead sits across the tricuspid valve. I think being cognizant of where the lead is and maybe not tethering the leads down if you can is a good idea. But I think we sort of have to take the hit of whatever tricuspid regurgitation that we see. It's a little hard to stay away from it. You certainly need to have enough slack so that the lead is not pulling. And unfortunately, that slack engages the valve a little bit more. So I do think we have to be careful.
Great. Dr. Chinitz, thank you very much. Stay with us because we're going to come back for an open discussion at the end. But at this point, I will introduce Professor Zachary Whinnett. Professor Whinnett is an electrophysiologist and cardiologist practicing at Imperial College NHS Trust, working out of the Hammersmith Hospital in London. He is the head of cardiovascular trials and epidemiology section at the National Heart and Lung Institute. He is the chief investigator for the HOPE-HF study looking at AV optimization with conduction system pacing, and the PROTECT-HF studies assessing the efficacy of conduction system pacing. He is co-author on the ERA consensus paper for CSP, and as a very early adopter of HIS and left bundle pacing technology, he was a co-author of the MELOS study, the multi-center European left bundle branch area pacing outcome study. This is a registry-based observational study with over 2,500 patients across 14 centers, and that's become a pivotal document for this discipline. With such extensive experience in these areas, Professor Whinnett will today present two case studies that demonstrate his areas of interest and research as they relate to conduction system pacing. Professor Whinnett.
Good evening from London, and thank you very much, Hayes, for the kind introduction. So straight to it, I'm just going to present a couple of cases. These are my potential conflicts of interest. So our first patient is a patient with an indication for cardiac resynchronization therapy and discuss the role of conduction system pacing. So our patient is a 74-year-old female with non-ischemic dilated cardiomyopathy, impaired left ventricular ejection fraction, symptomatic heart failure, and she was on optimal medications for heart failure. Of note, she's intolerant of Entresto and spironolactone. So my first question when I'm considering conduction system pacing as a method for delivering cardiac resynchronization therapy is to gain an understanding of the underlying electrical substrate. So this is most easiestly done with a 12-lead ECG. This is our patient's 12-lead ECG. We can see that she has a QRS duration of 154 milliseconds, so seems to be a good candidate for CRT. Now, the importance of the electrical substrate, of course, is that all patients with a left bundle branch block pattern don't necessarily have conduction block within the left bundle, within the left-sided conduction system. So on the left here, we have endocardial traces with a catheter placed on the septum, multipolar catheter. Very nice data from the Chicago group. And this shows a patient with left bundle branch block who's got clear block in the conduction system. So you can see his potentials and then no further potentials. So this type of patient, if we pace distal to the block, we can re-engage the conduction system, and there's a very high chance that we're going to improve both ventricular resynchronization, but also restore more normal physiological ventricular activation patterns. On the right, we have a patient who has a somewhat broad QRS, but we can see that there's intact conduction down the conduction system. So we see conduction potentials all the way down. And so this patient has intramyocardial disease, more distal disease, and therefore a conduction system pacing approach by itself is unlikely to deliver significant ventricular resynchronization in this patient. So and we know, so one of the reasons for considering conduction system pacing over biventricular pacing is that we know that it's possible to deliver more effective ventricular resynchronization with conduction system pacing. So this is data from a within patient comparison study which we performed, and we look at total ventricular activation time. We see that with conduction system pacing, we can deliver significantly greater reductions in total ventricular activation time. And that these greater reductions translate into greater improvements in acute hemodynamic function. So it's possible to deliver better ventricular resynchronization over biventricular pacing, but only in patients who've got the appropriate substrate, so only in patients who've got block in the left-sided conduction system. So it'd be nice to be able to identify in those patients pre-procedure whether we're likely to be able to have a beneficial effect with our CSP. So this is unpublished data from a series of patients with a CRT indication where we measured the electrical response using non-invasive activation mapping, looking for a reduction in the activation time or a change in left ventricular activation patterns or more physiological activation pattern. If we look at the 12-lead ECG, we assessed whether having positive Strauss criteria, so notching in lead 1 or AVL or slurring in V5 or V6, was able to predict whether we could correct the activation with conduction system pacing. We found that it had a good positive predictive value, so 83%. So if you have Strauss criteria, you've got a good chance that you're likely to be able to deliver ventricular resynchronization with conduction system pacing. Negative predictive value is not so good. So you may still be able to correct, even though the Strauss criteria aren't present. If we look using ultra-high frequency ECG, which is another way of looking at electrical dysynchrony, we found that even slightly better positive predictive value, but negative predictive value, again, was not so good. Another thing we assessed was looking at scar. So if there's not much scar in the ventricle, we've got good positive predictive values, so good chance of being able to deliver a conduction system pacing CRT. Again, negative predictive value, not so good. Our best way of being able to non-invasively identify patients who are likely to respond, electrically at least, is using activation patterns, using ECGI imaging. But of course, at the moment, this is not widely available. So if we go back to our patient's 12-lead ECG, she has notching in one in ABL, suggesting she's Strauss positive. And then she comes on the day of the procedure, and this is her ECG, so it's not that clear. But you see she has a ventricular ectopic, followed by a narrow QRS complex. So this is highly suggestive that she's got conduction block, which we should be able to improve with conduction system pacing. So and this patient was recruited to a study we're performing where we are assessing implanting leads at different sites within the conduction system, more basal and more distal site. So we implanted the lead, so we did continuous pacing as we deployed the lead, and we got to this position where we saw really quite impressive narrowing of the QRS duration compared to the intrinsic intrinsic ECG. If we look at our stimulus to peak in V6, we see that this was relatively short at 80 milliseconds. But if you look at V1, there's no clear R prime. So the question is, should we accept this position? So we've got good narrowing of the QRS, but should we stick with this position, or should we try to deploy the lead further? So one of the things when I'm making this decision is what I'd like to know is whether we actually have evidence of left bundle capture, or whether this is potentially just LV septal pacing. So Dr. Chinitz very nicely ran us through the ERA consensus criteria. So if we apply these to this patient, we looked for output dependent transition, which is my number one criteria that I like to look for, and that wasn't present in this position. If we look at our peak V6 peak time, it was actually 80 milliseconds, so very borderline, but not quite less than 80 milliseconds. And we didn't have a clear R prime. And we didn't do program stimulation. There was no potential present, but we wouldn't necessarily expect to see that because the patient was in left bundle branch block. So strict application of these criteria, we would say this is more likely to be LV septal pacing. We happen to be able to have a non-invasive activation map in this case, which we looked at after the case. And we can see here that this is consistent with LV septal capture rather than actually true left bundle capture. So we decided to add some extra turns, and we were confident to be able to do that because our injury, current of injury was still large and very positive, and the impedance hadn't dropped significantly. So we added extra turns, and then suddenly there was an abrupt drop, abrupt shortening in the stimulus to V6 time. So it went from 80 to 70 milliseconds, and then we see a clear R prime develop. And then we did output dependent pacing, and we can see with a decreasing pacing output, there's a change in morphology. So if you look at lead V2 and V3, there's a clear change. But also if you look at the lead electrogram, you can see that suddenly as we decrease output, there's the local electrogram steps out. So this is very clear evidence of output dependent transition, transitioning from non-selective capture to selective capture. And then if we look at our activation maps, which we happen to have, and you can see with left bundle capture, we get this very rapid apex to base activation, whereas with intrinsic activation, there was this much slower activation. Sorry, the video is not playing. But we also have invasive mapping, and during invasive mapping, we're able to see that there's early septal activation, but then very rapidly there's more distal activation that then transmits back up the septum. So you engage the conduction system and rapid activation of the lateral wall. So all these things confirmed that we had achieved left bundle pacing with the more distal position. So Dr. Chinitz again discussed this distinction between LB septal pacing versus left bundle branch pacing. And in terms of activation patterns, Dr. Corella very recently published this paper using ultra-high frequency ECG, which suggests that in patients with a CRT indication that left bundle branch pacing results in more synchronous left ventricular electrical activation, and this translates into a greater acute hemodynamic improvement. So in this case, we could have accepted the earlier lead position, but actually we wouldn't have achieved the optimal resynchronization for this patient if we hadn't deployed the lead a little bit deeper. Now, my second case relates to the difficulty with advancing the lead through the septum. So this was a 61-year-old patient with heart failure, is long-standing renal failure on dialysis and hypertension. They had a CRT-D implanted, but early displacement of the LV lead, so he was referred to us. We implanted a HIS lead in 2016, and he subsequently had an AV node ablation. However, he then presented with a rise in his HIS capture threshold to 3 volts, which resulted in relatively early battery depletion. This is the paced ECG during HIS pacing, which you can see is a fairly nice ECG, although not the narrowest ECG, which to me suggested that it's likely there was some degree of intramyocardial disease as well. So initially tried after we'd removed the HIS lead, I began to slightly regret it when I was having difficulty penetrating the septum with, we initially took a luminous lead. So when we think about potential mechanisms for failure to advance the lead through the septum, there are several different potential mechanisms. It can be due to inadequate contact or alignment with the septum. I was sure I had good contact. I even did I injected some contrast and could see we were well up against the septum. So a further thing can be that can inhibit the progress of the lead can be lead entanglement. But there were none of the clues to suggest that we had lead entanglement in this case. I was pretty sure that our problem was that there was a septal scar. So we know that septal scar can be an issue in terms of deploying the lead. This is a publication from our group where we performed MRI scans prior to attempted left bundle pacing. They didn't tell me the results. And we found that the major barrier to deploying a lead was actually the presence of septal scar. So in this case, what we did is switch to a stylet-driven lead. But even in the basal position and with the stylet-driven lead, I wasn't able to get through the septum. But the good thing about the left bundle pacing is that, of course, that we have options. So my preference is to try initially for a basal position, but of course we've got more options. And so what we did in this case is we decided to target the more posterior fascicle. So this is the electrogram as we deployed the lead, and you can see this is early during deployment. The QRS begins to narrow, but the LBAP time around about 120 milliseconds. As we get deeper, there's a beginning to develop an R prime in the V1. If you look at the V1, we see that. But the LBAP time doesn't really shorten. But then with another turn, we see an abrupt shortening of the LBAP. So it goes from around 120 to 90 milliseconds. And you can see the R prime becomes more prominent and a little bit later. So whilst the R prime here, so the LBAP time here is a little bit on the longer side, there was abrupt shortening and a step out in the RBAP time. Both of these things suggested to me that we were very likely that we'd now engaged the left bundle, and therefore we went to check for output dependent transition, and we observed that. So sometimes it's useful to use the clues that we get during the pacing to help us, because I think this patient had a degree of intramyocardial disease, which can mean that the sort of standard criteria can be a little bit more difficult to apply. So this was our final lead position and 12 lead ECG. So there are two cases which present some of the challenges and more complex cases for conduction system pacing, and I look forward to the discussion.
Thanks very much. Great cases. Let me say to everyone that's watching the webinar, we've had a lot of questions, and we're not going to be able to get through all of them, but we really appreciate your input and your interest. We'll get to as many as possible. Professor Whinnett, in your experience, are you noticing any difference between unipolar and bipolar pacing?
So it's a good question, because one of the things that so there's sort of pros and cons to think about. So at one stage, there was some papers coming out suggesting that maybe bipolar pacing would be more effective, because often with bipolar pacing we can get anodal capture, and therefore the overall 12 lead ECG looks a bit narrower, because the R prime that you get, which actually broadens the QRS, isn't so prominent, or can even disappear with bipolar capture. We did look at this in the study where we, within patients, we compared the activation time with unipolar versus bipolar pacing, so with and without anodal capture, and we saw that overall activation time was shorter with bipolar pacing with anodal capture, but LV activation time was the same, and there was no acute hemodynamic difference. And then the output the output required to capture the anode was a little bit higher. So probably there's some not useful for longer term outcomes. Of course, it depends on the situation. If you're implanting your lead into an LV port, some manufacturers you have to do bipolar pacing anyway. So I don't think there's convincing evidence of one being necessarily better than the other. Overall, there may be certain circumstances where it's one is better than the other, or more useful in individual patients.
Thank you. A number of other questions here. One that I think was inevitable: what percentage of your potential CRTP cases are now becoming LBBAP? And do you always have that as an option for those where LV lead positioning may be difficult or challenging?
Yeah, so in the UK, we're a little bit more conservative in the CRT population, because, of course, and in terms of applying conduction system pacing, because we have, on the one hand, with biventricular pacing, very robust data from large, high-quality randomized controlled trials saying that biventricular pacing improves outcomes. So, and we don't yet have data from large randomized controlled trials saying that there's at least equivalence with conduction system pacing, albeit the data we've had from registries is very encouraging. So we have to be a little bit more cautious, but it's a very useful bailout option, or if patients are recruited to studies, then conduction system pacing is the way. But if you ask, if in terms of knowing whether you're able to correct, then I think it's very useful looking at the pre-procedure ECG, as I said, the sort of Strauss criteria, and trying to get an idea whether it's likely that you're going to be able to correct. And it depends a little bit on your population. So for the DCM patient with not much scar, or you have a Strauss criteria, then a conduction system lead by itself is very, very likely to give you very good electrical conduction. Of course, we've got some data now from observational studies that not only can you potentially get better resynchronization with a conduction system lead, but actually procedure time may be a little bit shorter, capture thresholds may be even lower, and then intriguingly, there may be fewer ventricular arrhythmias. But of course, these findings need to be confirmed with large randomized controlled trials. But the data, these trials are now underway, which is very exciting. I think ultimately, sorry, interrupt. I think ultimately it's likely that the process may be conduction system lead first, and then if we can't get the adequate correction, then add an LV lead. Yeah.
Okay. So another question that came in. Is there any difference? Well, let me ask this. What is your advice if you're unable to penetrate the septum? Do you change position or do you change tools?
Yeah, so I think it's really important to work through the mechanisms. So if it's so the number one reason, particularly when you're starting out, is that it's just not getting adequate positioning and stability on the septum itself. So work through those things. Make sure that you've got good contact and that you're perpendicular to the septum. Because sometimes a very small movement, a little bit of anti-clockwise rotation on the sheath, will get you from pointing properly in terms of being properly orientated on the septum, in which case you go from a lead where it's difficult, you can't penetrate, and then it just immediately penetrates. So just a little bit of counterclockwise torque, maybe looking at LAO, and then it works perfectly. But there can be difficulty getting onto the septum, and you might need to switch tools. So particularly if it's a patient with heart failure and you can't quite reach, you might need to switch to a sheath that allows you to get and then the changing position to me often relates to scar. So if I think we're not getting through because of the presence of scar, then I will move to more distal position. Now, it's still a little bit of an outstanding question about whether more basal pacing versus targeting the conduction system more distally, whether one is better than the other. And again, this may be patient related. So in terms of, a bradycardia pacing probably doesn't matter so much if you target the more distal conduction system, but for a CRT patient, maybe it does.
So one last quick question for you before we switch to the general discussion. What curve or length of the Selectra 3D do you find most consistently successful? I tend to go for I'm just trying to think. It varies a little bit from case to case. Usually I go for the sort of mid-range mid-range cuts. Yeah. And that's the one I sort of take out and use as the first. But I'm not afraid to change. That's why that's the advantage of having more tools, and that's the great thing where we're at now, is that we're now getting more tools, and the different sheath may make all the difference for an individual patient. So don't be afraid to swap the sheath mid case, but often that one works for me. Thank you very much. I think we have Dr. Chinitz joining us again now, and some general questions that have come in. So I'll start, Larry, with you, if you would. Do you use the impedance to check how far you can screw the lead into the septum, or how do you use the impedance?
Yeah, so we definitely use impedance. It's a little bit of a task to get to the left septum without perforating, because we all know, and Dr. Whinnett showed very clearly, that sometimes one extra turn can go from septal to true conduction system pacing. So it becomes important. So we look at the trajectory of the impedance as we go along. Once we start to see it falling, we start to get concerned that we're getting close to that area. So we do use the delta of change in the impedance to assess when we get close to the septum. More recently, we're changing to current of injury on the lead, because that seems to be a little bit more predictive and give us a little bit more willingness to put an extra turn or so before. But I think you need some kind of a tool to get a sense of how close you are to perforation.
And just a quick follow-up on that. With the current of injury, how patient are you? If you get a great current of injury, but your thresholds are higher than you'd like, how much time will you take to see what happens to the current of injury and the threshold change?
So I think that's a really good question, and I don't have the answer to that question. But I will say that over the weekend, we did a case in which we had relatively high outputs initially, and by the next morning, the outputs dropped dramatically. So it took literally 12 hours at that point to come down. And we've seen that from time and time in some other experience. So I think that if you have reasonable capture with a large current of injury, usually we'll take that if we have good response and give it that extra 10 hours or so to come down. So I think you just have to be patient.
So another, yeah, go ahead.
So I was just going to add to, so I agree, current of injury is very helpful. And one of the things to look at, it's similar to impedance. Impedance will tend to go up like a bell-shaped curve and then begin to come down as you go towards the other end of the septum. And current of injury does a similar thing. It gets bigger. And actually, if you look at the magnitude of the current of injury as well as the pattern, but the magnitude tends to get smaller as you get towards the septum. And actually, you often, because to get true left bundle capture, you often need to be very deep in the septum. So that drop in current of injury is often a good sign that you've got deep enough, but that's the point to stop when you start seeing the amplitude reduce. And then just going to the question about capture thresholds, for me, it's always what the trend is. So you may get a slightly higher capture threshold acutely, but it will, if it's on a downward trend, usually by the end of the case, it's below 1. So you can be a little bit patient, put the atrial lead in. If it's still working its way down, even if it's sort of 1.5, you know that usually by the time you do the final check, it'll be less than 1.
So a quick question for both of you, and I know this has changed for some, others has not. Do you utilize contrast injection? And if so, do you do it before or after screwing into the septum?
I've traditionally not used contrast that much. So I tend to use it more if I'm a little bit unsure about the anatomy. For example, maybe in that case early on when I had difficulty that I presented earlier, where we're having difficulty penetrating the septum. So I want to make sure that I've definitely got good contacts, in which case there I might inject it whilst I'm at the septum. If the anatomy seems unusual, then you may do a contrast injection just to get orientated. But I know lots of people find it very useful. So it can help you orientate where the tricuspid valve is. Sometimes I will use I will just map with the leads to look for the His potential, because in a heart failure patient, often the anatomy is all very different. The valve is lower, the His is actually often much lower than you'd expect. So contrast can be helpful, or other clues such as looking for the His. And I'd certainly encourage people to use contrast if you find it helpful.
And Larry, what about you, NYU, for contrast injection?
Honestly, David, I think we have the same experience that Dr. Whinnett just described. I think we don't use it routinely, but we recognize that it can be very helpful, and certainly in difficult cases, we will employ that. But we don't use it routinely.
Thank you both very much. I wish we had more time because we've got more questions, as you might imagine. But I want to thank both of you. Great talks, great discussion. This is an area that's moving so fast, and both of you have contributed in a big way to the discipline of conduction system pacing. I also want to remind everyone that is on the webinar that 2 questions will come up, and we would ask you to take just a few seconds to answer those. And also, the audience, everybody attending, will receive the recording in the coming days. And so if you want to listen to parts of this again, or if you have colleagues that were unable to attend, please share it with them. So again, my thanks to both of you. My thanks for all of you at different time zones around the world taking time to be with us today. And with that, we will close out the webinar. Thank you.